Morning students, today we will see the last topic of respiratory physiology, that is applied aspects. So what is the significance or importance of knowing this applied aspects is that it forms a link between the basics of respiration and the clinical manifestations of respiratory diseases. So without having a basic knowledge of respiratory system, that is whatever we have seen till now, the functions of lung, respiratory and non-respiratory, and the mechanics of breathing and the ventilation and the work of breathing, airway resistance, and how the respiration is regulated, and what are the respiratory changes at various places like high altitudes and at high atmospheric pressures. So with the knowledge of all these things, we can easily identify the various respiratory pathologies. So in fact, respiratory diseases cannot be managed satisfactorily without a proper understanding of basic and applied aspects of respiratory physiology. So in order to understand the various disturbances of respiration, we need to know the breathing patterns. So what are the abnormal breathing patterns? First of all, the normal breathing rate and pattern is called eunia with a waveform of like this. And then the abnormal breathing patterns. First one is tachypnea, which is described as having increased respiratory rate. So with the waveform like this. And then bradypnea, decreased respiratory rate with the waveform like this. And then apnea, that is complete absence of breathing. So there is no recording of waveform, only a single straight line will be seen. And this is one more is hyperpnea, which is described as having increased depth and rate of breathing. So you can see the depth of breathing is increased. And then chain strokes and Biot's type of breathing patterns are comes under the periodic breathing. So they are having alternate periods of respiratory activity and apnea. So we will see about these two in detail later. And one more type is Kussmaul's breathing. So this is also one type of abnormal breathing pattern seen in especially diabetic ketoacidosis patients. They have tachypnea and hyperpnea. And one more is apneustic breathing. So the waveform will be like this. So here the patient have prolonged inspiratory phase along with the prolonged expiratory phase. We will see in detail about apnea, cessation of breathing. There is no movement of muscles of respiration and the volume of lungs remains same. And the airflow into or out from the lungs is not present, and the gaseous exchange and cellular respiration are not at all affected. So we will see the types of apnea are voluntary apnea, deglutition apnea, vagal apnea, adrenaline apnea, and sleep apnea. So voluntary apnea is nothing but the person voluntarily controls or stops respiration for some time. It is otherwise called breath holding. So the normal persons are capable of holding the breath for 40 to 60 seconds after taking a deep inspiration. And the deglutition apnea is nothing but stopping of respiration during swallowing process, so that the food or fluid will not enter into the respiratory tract. And the vagal apnea is it is produced experimentally in animals by stimulation of vagus nerves. And adrenal apnea is also occurs or produced after injection of high doses of adrenaline. Sleep apnea refers to the cessation of breathing for a brief period, that is only 10 seconds, during sleep in normal individuals. So it is related to the reduced sensitivity of respiratory center neurons to arterial PCO2 owing to the inhibition of central chemoreceptors. So other than these types of apnea, there are also some more types called apnea after hyperventilation, which occurs due to reduced stimulation of respiratory center because of CO2 washout caused by hyperventilation. And breath holding attacks are attacks of brief periods of apnea which occur in infants and young children, and generally they are precipitated by emotional distress like fright, frustration, pain or anxiety. So these attacks are harmless and stop by the age of 3 years. So now we will see sleep apnea syndrome. So what it is? It is a serious clinical problem or a disorder of respiratory control that affects middle-aged and elderly men. So it occurs in two forms, obstructive sleep apnea and non-obstructive or central sleep apnea. So what are these? Obstructive sleep apnea means, in the name itself, the word obstructive indicates there is something obstruction happening in the respiratory tract. So in this picture you can see, during sleep, gravity and muscle relaxation allows the tongue and surrounding soft tissues to fall back into the throat area, obstructing the air flow. Okay, so the tongue and other soft tissues, that is muscles like that, they will be falling back because of gravity and muscle relaxation, which causes obstruction to the air flow. So the partial airflow obstruction causes snoring. So the association of sleep apnea with extreme obesity is referred to as Pickwickian syndrome. And the other form is non-obstructive and central sleep apnea. So it refers to complete stoppage of rhythmic activity from respiratory centers. So there will be no respiratory muscle contraction during apnea. So it has been proposed as one of the many possible cases of sudden infant death syndrome. So here what is there? Central sleep apnea. There is complete stoppage of rhythmic activity from the respiratory centers. And here in obstructive sleep apnea, there is obstruction to the airflow. There is partial obstruction to the airflow producing snoring. So snoring, which you will be commonly noticing in your elderly grandparents. So that is because of this syndrome, sleep apnea syndrome. And the next few more disturbances of respiration are hypoventilation and hyperventilation. So hypo is nothing but decrease in rate and force of respiration. So what are the causes for this hypoventilation are depression of respiratory centers by some drugs and the partial paralysis of respiratory muscles. And the effects because of hypoventilation are hypoxia and hypercapnia are produced, which increases the rate and force of respiration, and again the patient may develop dyspnea. The hyperventilation is nothing but increase in rate and force of respiration, which is caused by exercise. So the most common cause of hyperventilation is exercise, which stimulation of in which there is stimulation of respiratory center by increased PCO2. Also voluntarily we can produce hyperventilation. And secondary to hypoxia, hyperventilation is also produced by stimulation of peripheral chemoreceptors. And the effects of hyperventilation are, immediately after hyperventilation there is hypoventilation for prolonged periods, and also apnea will be there for some time. In the next we will see dyspnea. It is otherwise called air hunger or shortness of breath. So it literally means distressed breathing. So increase in respiration without discomfort is called hyperpnea. So one is not aware of one's respiration till resting pulmonary ventilation becomes more than double. But when hyperpnea involves 4 to 5 fold increase in pulmonary ventilation, an unpleasant sensation of discomfort is felt. So this discomfort is called dyspnea. And the word air hunger is used as a synonym to dyspnea. So the desire for air or mental anguish associated with inability to ventilate enough to satisfy the air demand is the essence of dyspnea. So the height of hyperpnea at which dyspnea appears is called dyspnea point. So the predisposing factors for dyspnea are low vital capacity and the patients with reduced maximum ventilatory volume, and also patients with less breathing reserve. So what is the breathing reserve? It is the difference between maximum voluntary ventilation and respiratory minute volume. And next one, the most important criteria for the person to be considered as having dyspnea is that it is dyspneic index. It refers to the breathing reserve percentage of MVV. So the formula for dyspneic index, you all know it, and the normal value is 70 to 95%. So below which value the person is considered as having dyspnea. So it is how much? Below 60%. So if the dyspneic index is less than 60%, the person is definitely having dyspnea. So there are various causes for dyspnea. So the most important ones are respiratory disorders like asthma, pneumonia, and the cardiac failure. It is the most important condition. So in cardiac failure, what happens? In lying position, in cardiac failure patients, in lying position, there will be pulmonary congestion which causes dyspnea. So the dyspnea occurring in lying down position is called orthopnea. And other than that, the various metabolic disorders like diabetic acidosis, increased H plus ion concentration, uremia are all the causes of dyspnea. The next one is periodic breathing. So this one is very important short question for you. So what is periodic breathing? Alternate periods of respiratory activity and apnea are present in the periodic breathing. So it is of two types, Cheyne-Stokes respiration and Biot's breathing. So what are these two? We will. So this is the picture showing different types of respiratory patterns. The first one, normal respiration, that is normal tidal volume recording, and the Biot's respiration and Cheyne-Stokes respiration. These two are the types of periodic breathing. And one more type is Kusumal breathing. So this does not come under periodic breathing because there are no periodic type of respiratory activity and apnea like that. So it is simply hypernia, that is increased rate and force of respiration, and particularly it is seen in metabolic acidosis produced in diabetes mellitus, that is diabetic ketoacidosis, accumulation of metabolic acids like acetoacetic acid and beta hydroxybutyric acid which stimulate the respiratory center. So it is described by scientist Kusumal, so it is named after him, Kusumal breathing. So the Cheyne-Stokes respiration, it is of periodic type in which alternate periods of respiratory activity and apnea occur at regular intervals. So this word is very important, which is the main difference between Cheyne-Stokes and Biot's type of respiration. Cheyne-Stokes respiration, the periods of respiratory activity and apnea occur at regular intervals. And during the period of respiratory activity, remember the picture of this Cheyne-Stokes respiration. So in the respiratory activity, there is waxing and waning, that is increase and decrease of tidal volume is present, and the duration of each cycle is about 1 minute. The arterial PO2 and PCO2 fluctuate during each cycle. PO2 is lowest and PCO2 is highest at the end of apnea. And the causes for this type of respiration are mainly physiological, that is at high altitude and voluntary hyperventilation and during sleep in some normal individuals. And the other causes are pathological, that is mainly chronic heart failure, which causes increased circulation time from lungs to brain, and the brain damage due to increased negative feedback gain in the respiratory center, and uremia and poisoning by narcotics. So the Cheyne-Stokes respiration can be produced physiologically, that is by voluntary hyperventilation and also at high altitudes. So this is one more difference between Cheyne-Stokes and Biot's type of breathing. The next one is, so this Biot's breathing is also known as ataxic breathing, in which there are alternate periods of respiratory activity and apnea. So the main difference of Biot's breathing, which differs it from the Cheyne-Stokes breathing, is that This Biot's breathing occurs at irregular intervals. So there I have told you chain strokes, it occurs at regular intervals. Here it is irregular. So remember this, and there is no waxing and waning of waveforms of tidal volume. And these Biot's type of breathing never occur physiologically. Always it is pathological. Okay, so these 3 points you have to remember for Biot's breathing. So the main cause is central medullary lesion, and the other causes are meningitis, head injury, and medullary compressions like pontine hematomas, etc. So now we will see the various disturbances related to respiratory gases, that is oxygen and carbon dioxide. So they are mainly hypoxia, hypercapnia, hypocapnia, asphyxia and carbon monoxide poisoning. So out of all these we have completed in detail discussion about hypoxia. So now we will see little about these other things. So what is hypercapnia? It refers to increase in arterial PCO2. So normal value of PCO2 is 40 mmHg. So when hypercapnia is the primary problem, it will be associated with respiratory acidosis, because increase in CO2 generates excess H plus. Through the reaction, H2O plus CO2 produces H2CO3, which again dissociates to H plus and HCO3 minus. So in hypercapnia, it will be, if it is primary cause, it will be definitely associated with respiratory acidosis. So hypercapnia occurs due to defective elimination of CO2, as in reduced pulmonary ventilation and reduced effective alveolar ventilation due to VQ mismatch, and also accidental inhalation of CO2. And the next one is hypocapnia, which is a reduced PCO2, usually associated with respiratory alkalosis, because decrease in CO2 drives the reaction, that is H2O plus CO2 produces H2CO3. So that reaction will be happening in backward direction, resulting in decreased H plus concentration. So that is, it will be always associated with respiratory alkalosis. So this occurs due to hyperventilation. And next we will see little more about asphyxia. So what is asphyxia? It is a condition in which hypoxia associated with hypercapnia. So both are present, hypoxia and hypercapnia. Decreased PO2 and increased PCO2. So there are two types of asphyxia, local and general. In general, again, there are acute and chronic types of asphyxia. So the common cause of acute asphyxia are strangulation, drowning, acute tracheal obstruction, like in choking. So this is the most common picture of choking. So if you see the person holding his throat, this is definitely a sign of choking. So now we will see the physiological peculiarities of some of the pulmonary diseases to understand the pathophysiology of respiratory insufficiency occurring in these diseases. Various pulmonary diseases, we can categorize them into obstructive and restrictive types. So the common diseases in obstructive type of lung diseases are asthma, chronic bronchitis and emphysema. And in restrictive type, pneumonia, pulmonary tuberculosis, atelectasis, pulmonary edema, pulmonary effusion and pneumothorax, etc. So we will see first the respiratory tract, which is divided into upper and lower respiratory tract. So what are the structures which come under upper respiratory tract? So this picture is just for the basic knowledge, because some are not familiar with various words used in the pulmonary diseases especially. So that's why again I am telling you the basics. So what are the structures in upper respiratory tract? Nose, pharynx and larynx. And the lower respiratory tract covers the respiratory bronchiole, alveolar duct and alveoli. Okay, so first of all, after larynx it is trachea, and then bronchus, and then bronchioles. So till larynx it is called upper respiratory tract, and after larynx the trachea, bronchus and bronchioles. So in bronchiole, the respiratory bronchiole, that is the last division of the bronchiole, are called respiratory bronchiole. So in the respiratory bronchiole, this is the alveolar duct and the alveoli. Okay, so these are the few structures of the respiratory tract. In obstructive lung diseases, there is increased resistance to airflow and the person will be having high lung volumes. The patients find it easier to breathe at high lung volumes because this tends to increase the caliber of airways, greater radial traction, and thus decrease the resistance to airflow. So how the obstruction is present in the airway? So the airway lumen may be obstructed either partially or completely by excessive secretions like in chronic bronchitis or edema fluid or aspiration of food and fluids. And then airway wall, smooth muscles. Okay, so the muscles in the airway wall may be contracted like in asthma or thickened because of inflammation and edema in bronchitis. And the destruction of parenchyma outside the airway will decrease the radial traction, causing the airways to be narrow. So this is seen in particularly emphysema. So these are all the mechanisms by which the obstruction in the different types of diseases like asthma, bronchitis and emphysema is produced. So we will see a few details about that is asthma. The first disease which we will be seeing is asthma. So it is considered as an inflammatory disease of bronchioles caused by their hypersensitivity to foreign substances in air. So the functional abnormality present in the asthma is that there is airway narrowing by spasm of the bronchial smooth muscle, which is triggered by exposure to provoking agents like allergens or exercise. And there is also inflammation of the bronchial wall, predominantly eosinophilic or producing mucosal edema. And there is secretion of thick mucus into the lumen of bronchioles. So the main functional abnormality in asthma is that airway narrowing and the hypersensitivity to foreign substances and the inflammation of bronchial wall and also secretion of thick mucus into the lumen. And the symptoms are the person usually inspires adequately but has great difficulty during expiration. So it is a chronic lifelong disease with periods of remissions and exacerbations. So during an acute attack, the patient may have dyspnea or air hunger, cough, and then with repeated acute attacks, patient will get progressively fatigued and eventually respiratory arrest also occurs. So the pulmonary functional abnormalities occur in the patients over years. So there will be reduced maximum expiratory rate and increase in functional residual capacity and residual volume. But there is a reduction in tidal volume, vital capacity and FEV1. Okay, so all these pulmonary function tests I have already explained you. So just go through them once. So this is the picture showing the normal airway, asthmatic airway, and during an attack how the airway looks like. So smooth muscle walls are relaxed and there is narrowing of the airway by inflammation or the smooth muscle wall contraction, and there is here see fluid secretion and thick mucus, the tightening of smooth muscles and air trapped in the alveoli. All these are the functional abnormalities of the asthmatic patient. So the next diseases are chronic bronchitis and emphysema. So the chronic bronchitis is inflammation of bronchial tree due to smoking, dust and irritants. The mucosal inflammation is also exacerbated by the superadded infection. So it is characterized by increase in volume of submucosal glands and increase in number of goblet cells in the surface epithelium. The hallmark of chronic bronchitis are chronic cough and mucus hypersecretion. So these two are very important for identifying chronic bronchitis case. And the next one is pulmonary emphysema, which literally means presence of excess air in the lungs. So it signifies a complex obstructive and destructive process of lungs. Usually it is a consequence of long-term smoking. So emphysema develops because of two main reasons: airway obstruction and destruction of alveolar walls. So in airway obstruction, the smaller peripheral bronchi are thickened and distorted by scar tissue, and at segmental level there may be loss of bronchial cartilage. So these changes are termed as small airway disease. So I will show you in the picture. And the alveolar wall is being destructed because of obstruction of airway, making it difficult to expire and producing entrapment of air in the alveoli and overstretching of alveoli. So this will cause destruction of the alveolar cells. So this is combined with the lung infection. Okay, so these changes, destructive changes, are always combined with the lung infection. So usually there is loss of some elastic tissue because of proteolytic enzyme called elastase. So these are the pictures showing chronic bronchitis here and then emphysema. So here you can see this is smaller airway disease, okay, because they affect the peripheral bronchi. Okay, so here the airway is obstructed, excess mucus secretion and inflammation is present, and the normal alveoli are like this and the damaged alveolar walls. Causing entrapment of air in the alveoli and the overstretching. So normal alveoli size and the damaged alveolar size, if you can see, there is entrapment of air will be present in the damaged alveoli. So next we will see chronic obstructive pulmonary disease. So this is nothing but the clinical entity. It is the term used to denote a clinical entity having combined effects of chronic bronchitis and chronic pulmonary emphysema. So both the conditions, they are present in the same person. So we will call it as chronic obstructive pulmonary disease. The main physiological changes in this COPD are that increased airway resistance, which occurs due to chronic bronchial obstruction, and decreased diffusing capacity of the lungs because of destruction of alveolar membrane, and abnormal VQ ratio. So low VQ ratio occurs in area of lungs with bronchial obstruction, and high VQ ratio occurs in areas having marked loss of alveolar walls. And also there is increased pulmonary resistance due to decrease in number of capillaries owing to the destruction of lung parenchyma. This increased resistance may in turn cause pulmonary hypertension in these patients. So in this picture you can see the COPD causes are smoking, air pollutants and the genetic. And you can see the chronic bronchitis having inflammation and excess mucus, and emphysema, alveolar membranes are broken down and there is entrapment of air. And next we will see the restrictive lung diseases. So these are characterized by low lung volumes. Okay, so if you can remember the pictures from my previous class, that is pulmonary function test, I have shown you in obstructive lung diseases there is increase in the size of the lung, and in restrictive lung disease there is decrease in the size of the lung. So there will be restricted lung expansion because of abnormalities in lung parenchyma and pleura. So we will see few diseases type. So the pleural effusion, what it means? There is accumulation of the fluid in the pleural cavity. And this picture is of pneumothorax. So in the pleural cavity, there is entrapment of air or fluid in the pleural space. So that will reduce the size of the lung. So the most important and common type of restrictive disease is pneumonia. So it is an inflammatory condition of lung in which alveoli are filled with fluid and inflammatory cells. So the cause of pneumonia is usually a bacterial infection. So commonly pneumococcal or viral infection. So it also can result from non-infective cause such as chemical or radiation injury to the lungs. The functional abnormality in patients with pneumonia are restrictive pulmonary defect due to total replacement of alveolar gases by inflammatory exudates in the involved part of lung, and the VQ ratio is decreased because of lung perfusion is normal but ventilation is markedly decreased, resulting in physiological shunt formation, and hypoxia develops depending on the extent of involvement of lung parenchyma. And the symptoms of this pneumonia patients are, most common one is fever because of the bacterial infection, and compression of chest causing chest pain, and there is increased heart rate and the cerebral hypoxia in severe cases, and the retention of carbon dioxide occurs in later stages in severe disease. So this is the picture of pneumonia. You can see here fluid accumulation in the alveoli. And the next one is atelectasis. So it refers to the collapse of alveoli with absence of air in the involved parts. It may be developed due to obstruction of bronchus or bronchiole and the lack of surfactant, which increases the surface tension and causes collapse of alveoli, and also from the pressure from pleural cavity. In the previous slide I have shown you, if the pleural cavity is filled with air or fluid, it will cause pressure which will decrease the size of the lung. And the marked collapse of large portion of lung is a common cause of dyspnea. So in this picture, atelectasis, you can see airway obstruction with mucus or solid objects are the main cause, and also lack of surfactant. So there is decreased size of the lung. And the next one more disease is pulmonary edema. In this there is collection of serous fluid in the alveoli and interstitial spaces of the lung parenchyma. So the causes for this are pneumonia and increased pulmonary capillary pressure and harmful chemicals like fluorine or sulfur dioxide. And the diffusion capacity of lung is greatly decreased in this pulmonary edema. And there is marked alveolar edema which is fatal and causes sudden death due to suffocation. Thank you all for your patient listening. So by this topic we have completed the respiratory physiology. So whoever have not yet started the respiratory system, so try to read at least one topic a day. So this is very important system, having major essay questions like transport of gases, mechanics of respiration, regulation of respiration, high altitude physiology, like that. So don't neglect respiratory system. So at least start today. So now I will give you assignment in the PDF format. So I have not given clinical case studies this time. I have given the very short questions, 10 very short questions, each one 3 marks. So with your own knowledge, whatever you have read, or you can see the textbook, read and then write on your own. Don't copy from your friends. Okay, so write all the questions and then